Good evening, everyone. My name is Lalani Carlton Jones. I'm a consultant neuroradiologist at Guy's and St Thomas's and King's College Hospitals NHS Trusts. And you're watching a recording which was made at a later time from a previously delivered session on thoracolumbar trauma as part of the trauma module for the British Society of Neuroradiologists education programme. So this is going to be a recording that is delivered on thoracolumbar trauma, and this is going to be slightly differently from the live delivered session that was given earlier today. So just as an introduction, I work at a major trauma centre. We see a lot of thoracolumbar trauma, and a lot of the cases that I've used here today are those that I've seen myself from my colleagues, and I'm particularly grateful to Dr. Elizabeth Dick, who gave me a lot of her cases as well. So just to run you through what will be the session structure for today, we're going to have a look at an approach to imaging in thoracolumbar trauma. We'll have a look at some cases, scrollable cases on PACSPIN, and I will go through these cases with guided image interpretation. Some of these cases will be made available as hyperlinks through the curriculum support tool that as part of the training and education subcommittee we are creating, and I'll finish up with some learning points and imaging pearls to take away from today's session. So just to first go through a background to thoracolumbar trauma before we go through the cases and what I'm going to talk about today. So I'm going to cover anatomy of thoracolumbar spine and how that impacts upon fracture pattern, what the various different fracture patterns that we see are, some classification systems that are commonly in use, and what we should be putting in our imaging reports. So by the end of today's session, hopefully you will be able to recall various thoracolumbar injury patterns, how to recognize these patterns on CT and MRI, and describe how an MRI adds value in this setting, and then list the descriptors that you should be adding in your structured reports. So the reason that learning about thoracolumbar trauma is important is because 70% of all vertebral column fractures will involve the thoracolumbar spine. So these are common, and they often don't occur in isolation. They're often multiple injuries. And not an insignificant proportion of these cases will be associated with significant neural injury. So let's have a look at the anatomy and how that impacts upon patterns. So there are three distinct biomechanic regions within the thoracolumbar spine. So we've got the upper thoracic spine from roughly the T1 to the T8, T9 level, which is relatively rigid. So this is pretty stable, and that's because you have the surrounding rib cage and sternum. So therefore it requires a very high energy force to disrupt it at this level. So you tend to see fraction dislocation injuries at this level, or flexion injury is predominating. And then at the thoracolumbar junction, which is roughly the T9 to L2 region, this is actually the most common site of injury to the thoracolumbar spine. And that's because of its anatomic and biomechanical properties. You haven't got the ribs and the sternum to stabilize. You've got a transition from a thoracic kyphosis to a lumbar lordosis, and a transition from a relatively immobile to mobile segment. Also, your facet joint orientation is changing from coronal, where it's relatively fixed, to sagittally orientated. So it's more mobile in a rotational plane as well. And compression fractures, so your compression fractures, burst type fractures are most common here. And then from the L3 to the sacrum, you have a more mobile segment, a lordotic segment, where axial load injuries predominate. So here's just a slide that shows you an image of how the facet joints are orientated in the thoracic spine, where they're coronally orientated. Therefore, you're limited in flexion and extension. So you require a high impact force to be able to disrupt that. And so therefore, it's usually a dislocation injury that predominates at that level when fractures occur. Whereas in the lumbar spine, you have sagittally orientated facet joints. It's more mobile in that rotational plane. So you're going to get more compression type fractures. So why is spinal stability important, and what is spine stability? Well, spine stability is basically defined as the ability to prevent the development of neurological injury and progressive deformity in response to physiologic loading and normal range of movement. And it's dependent on both osseous and ligamentous components, and injury to either or both of those can result in spine instability that will require surgical stabilization. So I think it's an important concept to go through the Dennis three-column model, even though we've kind of moved on from this, because it's a good starting point. I mean, Dennis was a radiologist who looked at a number of thoracolumbar injuries and biomechanical studies on them and looked at stability following traumatic injury, and essentially proposed that instability occurs when you have injuries affecting two contiguous columns. So anterior and middle column, middle and posterior column, and obviously also a three-column injury is also unstable. So a simple anterior wedge fracture or just a sprain of the posterior ligaments is a stable injury, whereas a wedge fracture with rupture of the interspinous ligaments would be unstable, and a burst fracture would therefore always be unstable because at least the anterior and middle columns are disrupted. So in this Dennis three-column model, you have the anterior, middle, and posterior columns. So let's have a look at what exactly that comprises. So the anterior column is the ALL, the anterior two-thirds of the vertebral body, and the anterior annulus. The middle column is the posterior third of the vertebral body, the posterior longitudinal ligament, and the posterior annulus of the disc. And then the posterior column is the posterior element, so the posterior ligamentous complex, which we'll talk about in a second, and the posterior osseous arch. And spinal stability is dependent on at least two intact columns. And when two of the three columns are disrupted, it will allow abnormal segmental motion, so instability. So what is the posterior tension band then when we hear people talking about this posterior tension band? Well, essentially that is the posterior ligamentous complex together with the spinous processes. Now, if you think about the mechanical structure of the thoracolumbar spine and how you have the normal thoracic kyphosis and the lordosis, you have an anteriorly displaced center of gravity that essentially creates a compressive force downwards on the spinal vertebra. So that's this dotted arrow. And that's similar to the force on a crane lifting arm. So given this crane lifting arm is similar to this downward force. And then you get this resulting baseline flexion force, which is this arrow. And this is essentially similar to the tension on a crane's lifting cable. And this is essentially what the PLC does. It creates that tension within that. There's an anterior tension band as well, and that's essentially the ALL. But the posterior tension band refers to that combination of osseous and ligamentous structures. So what makes up this posterior ligamentous complex? So the posterior ligamentous complex basically is made up of the ligamentum flavum, which runs along the ventral aspects of the laminae, the interspinous ligament between the spinous processes, the supraspinous ligament at the dorsal aspects of the tops of the spinous processes, and the facet joint capsule. And these ligaments are strong ligaments. The supraspinous ligament is a strong cord-like ligament which connects the tips of the spinous processes from C7. Remember that above this, it will be the nuchal ligament. And so you can't see these structures on CT, but you can infer their presence by their location, and you can certainly infer disruption by a number of findings, which I'm going to discuss. So the ligamentum flavum would be here, then we've got the interspinous ligament, the supraspinous ligament, and the facet joint capsule. But you can see these structures on MRI, which is why this is a good tool for assessment of ligamentous injury. So here we have the black dark line of the ligamentum flavum running between the laminae. We have the interspinous ligament, and this is a pretty weak ligament, to be honest, between the spinous processes. So any kind of spinous process fracture will often disrupt this. We've got the thick cord-like ligament to the supraspinous ligament, and we've got the facet joint capsule. So why is the PLC so important? Well, when you have disruption to the PLC, that has a tendency not to heal and can lead to progressive kyphosis and collapse. So that's why the PLC, together with the osseous components, play a really important part of creating this posterior tension band that result in this important role of stability of the spine. And so therefore, we need to be able to assess whether it's disrupted. Now, we can't see these ligamentous structures on CT, but we can infer their disruption by various findings. So none of these by themselves are sufficiently accurate to diagnose or exclude a PLC injury, but it's more likely with two or more of these findings. So if you have a disruption of the interspinous or supraspinous ligaments, you're likely to get a splaying of the spinous processes. So you get a widening of the spinous, between the spinous processes at the level of the fracture. And then we can think about avulsion of the spinous process, so particularly horizontal fractures of the spinous processes that will disrupt the ligaments between the spinous processes. Widening of the facet joint will tend to disrupt the facet joint capsule, or this will be as a result of a fracture dislocation injury, which will be a sign on a CT when you see the widening that the joint's discongruous, or that there's been a distraction injury or a dislocation injury to the joint. And clearly, if you have a dislocated facet joint, perched facet joints, that is going to suggest that there's been a facet joint capsular rupture, because you can't have that without stretching, at least stretching or disruption of the facet joint capsule. And then finally, if you have a vertebral translation, which is clearly going to be a very significant injury, that is going to disrupt the PLC. So you always get a PLC failure when you have a vertebral translation injury that's significant. But remember that no individual finding is sufficiently accurate. You would need to have really more than 2 of these to be confident of that. And a local kyphosis of more than 20 degrees is also predictive. So let's have a look at some fracture patterns that occur in the thoracolumbar spine. So what are the types of fractures that occur? So I've graded these from least severe on the left to most severe. So compression, a burst, translation and distraction with these most severe involving the 3 columns. And we're going to go through these in turn. But if I can give a piece of advice, you often hear and see people in reports writing, you know, hyperflexion or hyperextension injuries. And whereas some of these mechanisms do have you know, findings that we commonly see, I think it's a mistake to write mechanisms of injury in report, because the truth is we don't really know how these mechanisms of injury occurred, and various mechanisms can lead to similar injury patterns, and retrospective inference of the injury mechanism based on your imaging findings can actually result in you making errors. So better to just describe the fracture morphology and the other components that we're going to go through on how we write our structured reports. So the most simple type of fracture is the simple compression fracture. So this is where this usually results from an axial loading force on a flexed spine, and you get an anterior column failure at 1 or more levels. And it tends to be a pretty stable fracture. And that's because we've only really involved the anterior column. So you've got an anterior column failure, you often get an anterior vertebral body wedging, there may be a cortical step break like here, you may see a horizontal sclerotic line parallel to the superior end plate, and that's due to the trabecular impact of bone, and you see a fracture. You may see a fracture of the superior end plate, less commonly the inferior end plate. Key thing here is the posterior cortex of the vertebral body is intact, and that is what distinguishes it from a burst. We often see in reports written by the trainees that, you know, this is a compression fracture when it's actually a burst fracture. If it involves the posterior cortex, it's a burst fracture. So the middle column is, strictly speaking, in simple compression fractures, stable, and on MRI you can see the pattern of edema, acute edema, T1 hyperintense, stir hyperintense, and you can even see the fracture line on the MRI. Okay, and then moving on to a burst fracture. So this is where you get a comminuted fracture. It's a fracture of the anterior and middle column failure, and often posterior column as well. You often get an anterior wedging, and you get disruption of the posterior vertebral body cortex, and you get a retropulsed fragment into the canal. It's important to comment on the degree of canal narrowing, and, you know, clearly the more severe the canal narrowing, the greater the risk of neural compression. Often that can be known about clinically with the type of grading of the patient's neurological status. You often get a neural arch fracture, often get a split in the lamina or interlaminar region, and you will see this interpedicular widening on CT coronal images, which is where you get an interpedicular widening at the level of the fracture, because we've got a burst, so we've got a split apart of the ring. And this is an unstable injury, clearly, because it involves at least 2 contiguous columns, and there's going to be a risk of progression of deformity, and there's a neurological deficit in a large percentage of these patients. It's mostly an unstable injury. So can a burst fracture ever be stable? Well, that depends on what the patient is doing clinically, if there's neurology, on the degree of retropulsion and posterior column involvement. So clinically, if there's a neurological deficit, they're likely to go for surgery. CT findings, if there's greater than 50% anterior vertebral body height loss, because that is going to be predictive of developing a worse kyphosis. If there's already a kyphosis at that level that's greater than 20-25%. If there's a significant degree of spinal canal narrowing, obviously you will often know that by the patient's neurological status. And sometimes if there's rotational malalignment, because if there's a rotational fracture, that's often a sign that fragment of bone is not going to reduce by itself or by simple ligamentotaxy. And even when they hike the vertebra up, they often will need to push back those fragments using a reverse angle instrument. And on MRI, if there's evidence of PLC injury, they'll often need fixation, or clearly if there's any evidence of neural compression or injury. And then we're going to move on to fracture morphology being the distraction type. So the chance type fracture. So this is a high energy injury. It involves 3 columns. Often the posterior and middle columns have the failure in tension, and then you can also get an anterior column failure in compression. And these are different from burst and compression fractures, which are due to just simple compression. Here there's a severe tensile force. The highly unstable injuries, most have a severe neurological deficit. And these are often horizontally orientated fractures and distracted fractures. A fracture can transect bone or disc and ligamentous structures. And the imaging appearances are those of you get the distraction of the neural arch, and you often get that associated anterior fracture as well. And not insignificant proportion of these are associated with abdominal trauma as well, often a mesenteric or a bowel injury. So that's important to assess for as well. And then the final fracture morphology is the most severe one, really, the translation dislocation. And these result as a result of violent complex forces. So usually fall from a high suicide attempts, high speed motor collision accidents. And this is a 3-column injury. It's most have a severe neurological deficit, and it's essentially a traumatic spondylolisthesis with a fracture of the posterior elements, with or without fractures of the vertebral body, which they usually are. There's, usually severe ALL, PLL disruption, PLC failure, almost always, because we've got that translational element which will have ruptured the PLC components. And there's often horizontal fractures through the facets, neural arch, and facet joint dislocations as well, fracture dislocations. So here we've got some examples where we've got anterior translation of this vertebral body over the lower vertebral body, which is fractured. We've got severe canal narrowing here, so likely obliteration of the spinal canal. Here we've got lateral translation of the vertebral column. And as you can see, all of these will clearly have resulted in a severe neural injury. So just to look at those in comparison with each other, from most severe, least severe on the left and most severe on the right, with the distraction and translation being 3-column injuries where there will almost always be PLC failure. So when do we worry about the so-called minor fractures? So there's been a recent review published in Clinical Imaging this week, which basically showed that transverse process fractures are the most common fractures of the thoracolumbar spine. And they often don't occur in isolation. So they often occur with other contiguous or non-contiguous vertebral injuries, and often occur with abdominal trauma. So if they're associated with other major injuries, they're not really minor fractures. And transverse process fractures that involve, for example, the C7, T1 and T2, and the L4 and L5 levels, you should think about the brachial and lumbosacral plexus injuries respectively. So here in this study, we've got bilateral transverse process fractures at T11, also at T12 there were. And here what you can see a devascularized left kidney. We've got an anterior abdominal wall hematoma on the right. The patient also had liver injury. Got another patient here who had a right transverse process fracture. You can see they have a traumatic anterior diaphragmatic wall hernia. They had multiple grade liver lacerations and hematomas. So I just want to quickly move on to disc injury. So disc injury is important to assess for, because for surgeons particularly, this may upstage a single column injury to 2 columns and may tip the balance into doing an operative fixation. So on the left, we have grade 0, which is normal. You can see the normal structure of the disc annulus and the nucleus pulposus. And then I've shown you grade 1 injury and grade 2. I've first just shown you the disc, which is abnormal below, and then a reference disc, which is the level above, where you can see the normal anatomy on stir. So grade 1 is where you've got hyperintense signal through the disc, and that is just an edematous disc. Where you can see some hypointense components, that is intradiscal hemorrhage. So that's just a close-up on those discs where you can see that intradiscal hemorrhage. And then a grade 3 is where you have a rupture or discontinuity in the annulus, and you've got herniation of disc material into the vertebral body, into fractures. So now let's have a look at some classification systems. There's lots of different classification systems There's no universally accepted right one. The two most commonly used systems that I've experienced in my practice are AO Spine and Telix. And they both got their benefits and drawbacks, and each incorporates various features of price systems in an attempt to basically classify them in a way that is meaningful for clinicians. But it's not a question of which so much is best, but which is most suited to accurately communicate your findings between your own clinicians. So by all means, take as much as you want away from this talk, but there's no point putting fracture classifications in, for example, an AO Spine in your reports if your clinicians don't know what you're talking about or they don't use them. So it's important to know what your clinicians want out of your reports, and particularly, if they do want a classification, then that you use what's important for them. So the problem with the Dennis 3-column model is that it doesn't take account of the patient's neurological status. It's therefore can't be used to guide surgical intervention. So this is where the spine trauma study group came up with the thoracolumbar injury and classification and severity score. And this is where they looked at the injury morphology, grading it from least severe to most severe, as we've discussed, from compression, burst, translation, and then distraction, those injuries being most severe, then looking at the PLC status to look and see if this is intact, indeterminate, or injured, and then looking at the neurological status of the patient. So if this is a nerve root injury, a partial or complete injury, or cauda equina. And then if they have more than 5, then that is tipping the balance into surgical management, whereas the 4 is a bit more of a grey area, and that's where it can be important to look for discal integrity, for example, to see if that tips the balance, or if there are other features, for example, like kyphosis, that can decide on whether you're going to operatively manage those patients. And so I'm now going to move on to AO Spine. So this is one our surgeons like, and this consists of only 3 classes of thoracolumbar injuries. So this looks at compression, distraction, and translation injuries. And lots of surgeons I know do use this, but it's not safe to assume your clinicians are familiar with it. So just make sure that if you are going to classify this, that your clinicians know about it. So they look at the morphology of the fracture, and we're going to go through those. The neurological status, similarly to Telix, and modifiers. So if you have, for example, a compression type injury, do you have the presence possibly of a PLC injury? Like, do you have any of those suggestions that we've talked about on CT? Or do you have any comorbid conditions? So does the patient have ankylosing spondylitis or DISH or osteopenia that will upgrade the fractures? So let's have a look at some of these in a bit more detail. So AO injury morphology A, the compression type fractures. But firstly, we've got AO0, which is the minor non-structural fractures. But remember, they're not minor if they're associated with an abdominal injury or other associated vertebral fractures, which these often are. So here we've got transverse process fractures. So then we've got the wedge compression. Here's simple wedge compression, fracture of the superior end plate here, and superior anterior corner. And here we've got another fracture of the anterior superior corner. So this does not involve the posterior body cortex, and it doesn't involve both end plates. Then you've got a pincer split type fracture, and they involve both end plates, but don't involve the posterior cortex. So here's an example on the sagittal. You can see it involves the superior, the inferior end plate, anterior also, but their posterior cortex is intact. So there's no retropulsion, there's no canal narrowing. And then we have the A3, which is the incomplete burst. So this is where you have involvement of that posterior cortex now, but only involvement of one end plate. It's usually superior. And these are often associated with retropulsed components into the vertebral canal. They're often associated with a laminar split. So here's an example of incomplete burst. You've got the anterior and posterior cortex. The inferior end plate is intact, but you can see that this dorsally retropulsed component has narrowed the spinal canal. It's a bit rotated, this component as well. Here's it on MR. You can see that that inferior end plate is intact, but it's because of this that it becomes a complete burst, the involvement of both the anterior and posterior cortices. Now, a complete burst now involves both the superior and the inferior end plates and the anterior and posterior cortices. And they look the same on the axial, basically. They can cause similar degrees of, if not worse degrees of canal narrowing, and again, often associated with this interlaminar or laminar crack. Here you can see that there's fractures through the superior and the inferior end plate and retropulsion of that component. So that's the most severe type of compression injury, or a complete burst. So then we move on to the distraction type injuries. So these are the chance type fractures. So the first type is the transosseous tension band, which is a purely osseous chance. The B2 is the osteoligamentous chance, and the B3 is a hyperextension injury, not a hyperflexion. So the first two result usually as a result of hyperflexion, but like I said, try and avoid using the mechanism terms. So in the first type, we have the classic chance fracture, which is a pure transosseous tension band disruption. So these disrupt the pedicles and the spinous processes in a single vertebral level. So you get a physical separation between these fractured bony structures, and a distracted horizontal fracture through the vertebral body is often, but not necessarily always, present. So here we can see that fracture of that spinous process, which is going along in this horizontal line. You can see that corridor of injury, and you can see also that they have a fracture of that vertebral body with that anterior superior corner fracture as well. And here you can see on the coronal imaging, the fractures are orientated in that horizontal plane. Then the B2 is the osteoligamentous disruption, which is basically involvement of the bony capsuloligamentous, and they involve an intervertebral body level with disruption to the posterior tension band ligaments with or without the posterior bones, and usually complete separation of the capsuloligamentous or bony capsuloligamentous structures. And again, this can include the anterior structures. So in fact, a type A fracture, compression type fracture, is often present, but that should be specified separately within that. So having a look at this case, you can see that there's a fracture through the pars at this level, through the pars interarticularis. You can also see that it's involving the superior articular process, involving at the level of that facet joint. So the facet joint capsule is likely to be involved, and non-congruent. You can see that there's a widening of the interspinous processes. So we're likely to have interspinous or supraspinous ligament disruption, as well as involvement of that facet joint. You can see that there's an associated fracture of the superior aspect of that vertebral body, which is often the associated compression component. And you see that again, that's playing of the spinous processes. So we've got an inference that there is an injury to the PLC, and that's confirmed when we did the MR. So you can see that there's a defect in the ligamentum flavum at this level. Along the line of that injury, you can see edema within the interspinous ligaments between the spinous processes. And then we've got B3, which is one of the classic sort of hyperextension injuries. So these are failures in the anterior tension band. So failures basically in that anterior tension band. So often we see these in the fused spine. So for example, in the middle image, this is in a patient with ankylosing spondylitis. That's why you can see fusion along these levels. And you can see this crack in the middle of the vertebral body at this level. And that's because it's been distracted apart at that level. Here at the first image, you can see there's been a widening of the anterior intervertebral disc space at this level, and that's a fracture there. And again, along that split in the middle of that vertebral body. And then finally, we have an annular tear of the disc along the line of injury here. And then the final type of fracture that we need to talk about are the translational type injuries. And these are the most severe type of injuries. And these aren't subclassified in the AO spine because there are many different types to this. They can have specific additional injuries such as, type A injuries or facet joint injuries, and they should be classified separately. So here we have anterior translation of this vertebral column upon this. We've got the lateral translation here. We've got another anterior translation. You can see fracture that's involving the lamina, probably the pars interarticularis here. You've got another fracture of the anterior superior corner here. So these are specific additional injuries, but you can see that they're all different translational type of injuries. So what should we include in our imaging reports? So when we report CT thoracolumbar spine, now this list is by all means not exhaustive, but these are the things that I think you should include if you have fractures of the thoracolumbar spine. So firstly, I think it's important to describe the fracture morphology. So is this a compression type fracture, a burst type fracture, translation, or distraction? And if you know that your surgeons, for example, or your clinicians like AO spine, feel free to classify it in that way. You should look at the percentage of vertebral height loss. That's important in deciding stability and eventual kyphosis. What is the degree of canal narrowing? And what is the degree of actual kyphosis at this level? And then we look at PLC injury predictors that we discussed. So the facet joint widening, the interspinous distance widening, the spinous process avulsion fracture, and the vertebral subluxation or translation. And then importantly, other injuries. Are there any contiguous or non-contiguous fractures? Now, often these vertebral injuries do not occur in isolation. There are often fractures at other levels, associated transverse process fractures, but also severe type fractures at other levels, sacral injuries, etc. And especially in patients who have fused spines, be careful, they may have fractures at multiple levels. And then you look for the associated visceral injuries. So there is in the abdominal, bowel, mesenteric, vascular injuries that are often associated with these high energy impact injuries. And these are more commonly picked up now because often these patients have had full trauma protocol CTs, which will be reported as structured reports. And then on MRI, what should we look for? So clearly what MRI adds is a clear delineation of discal and ligamentous injury, which alters grading of stability, and clear delineation of neural compression. And all of these will lead for the decision for operative management. But we're still going to look at the osseous injury, the morphology as per CT. So what type of fracture is it? The degree of vertebral height compression, the degree of kyphosis, canal narrowing. But we can look at discal integrity, which we can't really assess on CT. And remember, I said that's important because that may upgrade a fracture. Then we'll look at the ligamentous status, so carefully assessing for the continuity of these ligaments. So continuity, are there any defects? Do they look thinned? Can you see them? Do they look edematous? ALL, PLL, supraspinous ligament, ligamentum flavum, interspinous ligament, and the facet joint capsule. And then we'll look for neurological or other injuries. So is there any compression of the caudal conus? Is there any signal? Does it look edematous? Does it look transected? And similarly with caudal equina and nerve roots. Is there any evidence of epidural or subdural or intrathecal blood? And is there any evidence of paravertebral or prevertebral injury? So at this point, we're going to go through some cases. Now, because this has been recorded at a later date, I'm going to go through select cases only. So, case 1. So this is an example of compression type fractures, but these are two separate different types of classification. So here we can see we have a fracture of L3. It involves the anterior superior corner. There's also fracture through the mid aspect of the vertebral body that extends to involve the posterior cortex. So this is an example of a burst fracture. There's no involvement of the inferior end plate. So this is an incomplete burst, or what we would classify as an A3 type classification. And when we look at this fracture on the axial imaging, you can see that there's significant dorsal retropulsion of that component, resulting in likely, at least 70% narrowing of the vertebral canal at this level. You can see that there's an associated interlaminar fracture at this level that's commonly associated with burst type fractures. At the level above, we have an anterior superior corner fracture, doesn't involve the posterior cortex, doesn't involve the inferior end plate. So this is a simple compression fracture. When we look at the MRI for this study, what we can see is that that fracture delineated more clearly here. We can see that there's evidence of discal disruption with herniation of disc content into the fracture site. And another interesting finding from this is that we can see that there is evidence of epidural hematoma within the anterior epidural space, which is extending caudally from the level of the fracture. So if we look at this level, you can see that there's epidural blood that's extending. And if we look at the level of going down from the axials here, we've got the level of the fracture here. And you can see that the bone is retropulsed into the vertebral canal at this level. And here you can see, as we're going down, you can see that the cauda equina nerve roots are within the vertebral canal at this level, but you can see that there's anterior epidural blood. And if we go further up from that, we can see that some of that does become compressive as well. Another interesting finding with this was that we thought that there could have been a focal discontiguity of the theca at the level of the injury. So we wondered if there could have been a focal dural tear at this level with a tiny amount of CSF signal that's seen dorsally. And actually, when we go further down the vertebral canal, you can see that there's some fullness to the dorsal epidural space here, which looks as though there's fluid within here, as well as it doesn't look completely fluid signal intensity like within the theca. So we wonder if that's a bit of fluid mixed with blood secondary to a small focal tear in the dura associated with that fracture. So moving on to case 2. So here we have a case of a complete burst fracture this time. So we know it's a complete burst fracture because we can see that there's involvement of the superior and the inferior end plate, as well as involvement of the posterior cortex. You can see that there's marked retropulsion of osseous components into the vertebral canal at this level, and you can see that that's completely obliterated the spinal canal there. So there's likely to be a severe injury at that level. I mean, it is at L5, but there's likely to be a cauda equina at that level, and there indeed was. And you can see associated that there is that interlaminar crack that's often associated with these burst fractures. And the reason I thought this case was important to show was because this patient has multiple other injuries. You can see that they have a fracture of the lower sacrum and sacrococcygeal junction that's complex. There's pelvic visceral injuries as a result of that complex fracture. And also, importantly, one of the key findings here not to miss is that they have an aortic transection. So marked mediastinal hematoma, probably better seen on this. You can see they have an aortic, lots of mediastinal hematoma and that focal aortic transection at that level. And the more you look, the more you see. You can see there's devascularization in part of the left kidney as well. So moving on to case 3. So here's another example of a complete burst fracture. So we have fracture involving the superior and posterior cortex. There's a fracture that's split through here, so we've got involvement of that inferior cortex as well. So it's a complete burst fracture, or AO spine type A4. And one of the interesting things I thought from this is clearly you can see that they've got marked retropulsion of these components into the vertebral canal at this level, where there is significant canal narrowing. And we've got, again, an associated interlaminar split at this level, you can see here. But one of the interesting things that I thought was that when you look on the soft tissue windows, you get the impression that below the level of the fracture, you can see the dorsal and lateral epidural fat, and then you get loss of that anterior epidural space and almost an acute angle here that is suggestive that there's a fullness in that anterior epidural space. And CT is pretty difficult to assess epidural hematomas on, but there's just a suggestion that you've got something filling that anterior epidural space, because you can make out an acute angle within the fat here. And then the more you look, the more you see there's a little blush within that region which doesn't confine to bone. So that's making you think, could that be a bit of contrast blush related to a bit of ooze into a hematoma? And when we look at the case on MR, that is exactly what they had. So you can see here, again, that example of the complete burst. And you can see that there's retropulsion into the canal, and you can see that there is blood layering within that anterior epidural space. So if you look at the level of the fracture, here is the bone that's retropulsed into the canal. Here's that laminar crack. And as we go further down, you can see that there is epidural hematoma anteriorly. And also just within the theca, you can see that the nerve roots are a little bit indistinct, suggesting that there's probably some intrathecal blood, possibly some subdural blood even. As we go further down, it might be a bit more evident. But yeah, so there is at least anterior epidural hematoma and possibly some intrathecal blood as well. And this is also a good MR to show some of the ligamentous injury. So here we can see that there is disruption in the anterior longitudinal ligament here. You can see that this black line becomes discontinuous here. Similarly, the posterior longitudinal ligament is gone. I think it's difficult to assess the flavum here. It looks a little bit more intermediate grey, but it's difficult to say whether that's completely gone. But you can see that there's edema in the interspinous ligament for sure. The interspinous ligament is gone. The supraspinous ligament, I think it's pretty difficult. There's certainly some edema deep and superficial to that, so potentially it looks a bit thin there. That may be disrupted or at least indeterminate. So now we're going to move on to case 4. So case 4, there are a couple of findings on here. I mean, you can see that they have a complex 3-column injury of that distal sacrum, and clearly that was also resulting with pelvic visceral injuries. But the main fracture that I want you to pick up here is this chance type fracture. So this is this osteoligamentous front that we're talking about involving that L1 level. So let's have a look at that in a bit more detail. So you can see here that this is a horizontally orientated fracture that transects through that spinous process. The line of the injury involves, where it's come out, it's going to involve that interspinous ligament almost certainly through the flavum at this level. And look at the line of injury continuing along in that vertebral body where you've got a compression fracture as well. And you can see on the axial here, we can see the laminar crack, so you can see the spinous process fracture, the laminar involvement. So there's likely to be also a flaval injury as well. So this is this classic osteoligamentous chance fracture, so not just involving the osseous posterior tension band, it's probably involving the ligamentous components as well. And when you look at the spinous processes at these lower levels, if I could bring you back to the original, if you look at the spinous processes at the lower levels, they're closer together, but look at the level of the fracture, they've been separated. Okay, so this is the osteoligamentous chance. So we've got inferred signs of PLC failure. There's likely to be, if it's a chance type injury, we pretty much know there will be a PLC failure anyway. So now to move on to case 5. So just looking at this spine, you can see that there are long segments of osseous-like, band-like fusion across the anterior aspects of the vertebral body. So immediately you might be recognizing that this is a patient who has DISH, so diffuse idiopathic sclerotal hyperostosis. And that is indeed what this patient has, and they have long fused segments, some segments which aren't fused and some segments which are. Now, this is important to recognize, because patients who have fused spines, whether it's as a result of DISH or ankylosing spondylitis, often get fractures with trivial trauma. They get fractures within the ankylosed segments, as well as at the junctional zone between the fused and the non-fused segments. And the longer the fused segment, the greater the risk of fracture. They're often 3-column injuries, they're often transverse injuries, and often the long segment of fused spine can act as a lever arm. Therefore, you have, they can be very unstable. They're more prone to displacement of that mobile segment. So what do we have going on here? So we had to be very careful in these patients. There's likely to be an injury, even with a trivial trauma. And if you're unsure, you should MR the patient if you can't spot a fracture on the CT, because these fractures can hide in these studies. But here, there are a couple of levels of injuries. So here we have a fracture that's running through horizontally through the mid aspect of this vertebral body. And then when we look at the upper thoracic spine, we see that there are several horizontally orientated fractures through a number of levels. So T1, T2, and T3. So let's look at those in a bit more detail. So here we can see that we have a fracture that runs through T3. It's axially orientated fracture involving the T3 vertebral body. It involves the pedicle and the pars. You can see the fracture through the pars. It involves the facet joints and the laminae. The spinous process of T2 is involved. You also got involvement of that inferior articular facet. and therefore you'll have a disruption of the facet joint capsule. Then look also above, you have fracture of the T1 spinous process. So again, you're going to have an also involvement of that facet joint, fracture through that facet joint as well. So you're going to have disruption of that facet joint capsule. So we've got a multi-level chance here where we can see these horizontally orientated fractures, giving us evidence of osseous failure of the tension band, as well as the suggestion of ligamentous failure, because it will involve the facet joint capsules. And also, when we look at these abnormally long spinous processes that we often see in patients with DISH, if you look at the levels below this, those spinous processes are closer together. When we look at the levels of the fracture, they're widened, indicative of that ligamentous injury as well. So we've got a multi-level chance type fracture here. Now, what's going on at this lower level? Well, this is where you can see we've got fused segments that are the level above and the level below, that they're acting as struts. So what's happened is you've likely got a hyperextension injury where it's been stretched back and you've got a crack that's opened up. So you've got an anterior tension failure. That's resulted in a split in this vertebral body. Also involves the superior and the inferior end plates. So that has, you basically got several types of distraction injury within one spine. And the key learning point with this is that the fused spines in patients with DISH and ankylosing spondylitis and other fused spines are prone to getting fractures even with trivial injury. So don't take a chance to have a low threshold to MR in these patients. They can often be difficult and not clearly conspicuous on initial CT imaging. So it's often a good idea. And sometimes you may just see an anterior widening of the anterior intervertebral disc space, and they've got significant discal injury on MRI. Right, and then to look at case 7, we are going to look at this case of a translational injury. So this is an example. I'll just bring up the CT. So here is the CT for this patient. Zoom in on this. You can see here we have a translational injury, and we've got a failure of, we've got a translation of, I think this was T10 over T11. So we've got fracture, burst type fracture of T11. And you can see also that there are fractures through the pars interarticularis at both these levels. So I'll just make that a bit more obvious. Zoom this up a bit. So here you can see that you've got that burst type fracture of the vertebral body. Here we've got the fracture through the pars bilaterally. We've got a fracture of the anterior superior aspect of the spinous process, which is extending to involve the laminae bilaterally. And you've got these superior articular processes, which have been split by these pars fractures, have migrated forwards anteriorly with the translation. They've been pulled with it and into the neuroforaminae bilaterally at this level. So we are going to have a PLC failure, posterior tension band failure, both of the osseous and the ligamentous components at this level. Now, when we look at the MRI, this is a good one to show you some of the focal ligamentous deficits. So let me just zoom up on the stir. Okay, so here we can see that there's probably a focal disruption in the ALL here. You've got a little bit of buckling of the ALL, but there's probably a focal disruption there. There's almost certainly a disruption of the PLL. We can't see that black line, it's become discontinuous here. And here we've got quite a stunning flaval defect. So we've got a flapping of this ligamentum flavum in the breeze here. So this is the flavum, and a disruption of the flavum at that level. Now, we've also got the interspinous ligament disruption here. So you can see here there's edema within the interspinous ligaments as well. And also you can see that there is disruption of the supraspinous ligament. So here you can see this cord-like ligament here. Here you can see this thick cord-like ligament here, this black ligament, continuous, 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 and here it is flapping in the breeze. So that's been disrupted. So you've got a supraspinous ligament disruption, interspinous ligament, ligamentum flavum. And then when we look at the axial sequences, what you can see is that you have clearly at the level of the injury, you have cord compression. But when we look up at the level above, here we've got the T2, here we've got the black line of the theca, we've got fullness, likely hematoma within that epidural space. Here's the spinal cord. It looks edematous, swollen, it's got signal change within it. And as we come down, you can see that it's even more swollen, even above the level of the injury. And that's because we've got marked compression at the level of the injury, which is here. But remember that flaval defect that I showed you, what we've got is we've got cord here, and this is the thecal margin here, and we have cord herniating through that defect within the parenchyma. Here is that cord herniating through that flaval defect. And here again, just to remind you of the various ligamentous disrupted components, we have an ALL disruption. Here we have a posterior ligamentous, we have a PLL disruption, flaval disruption, interspinous ligament, and supraspinous ligament disruption. So I think this was a good one to show the various ligamentous disruptions. Also here you can see that there's clearly a discal injury at both these levels. The disc has been disrupted with herniation of this material through into the fracture site. Okay, so this is a case to show that not all injuries to the thoracolumbar spine are as a result of blunt trauma. This is a penetrating injury. So what you will be able to see is you'll be able to see levels of, you can see locules of gas within the paraspinal soft tissue, so subcutaneous emphysema, and there is actually an injury tract which traverses through the transverse process of the left T8. It involves that pars interarticularis. So let's have a look at these in a bit more detail. So here you can see that there is involvement of that pars interarticularis, there's involvement of that superior articular process and the supraarticular facet here, so there'll be disruption of the facet joint capsule. You've got a lamina, a little lamina shard of bone which is projected dorsally into the canal, and then also you can see this little posterior superior corner split here, so probably a PLN injury and a little fracture here, which is suggesting that this has traversed through the theca and probably the spinal cord at this level. And when we look on the axial images, we can also see that there is a fracture, bony fracture as a result. Well, it'll be a penetrating injury fracture as a result of this stabbing, and this is going through the lamina at this level. You can see that retroportion of the bit of that lamina, bit of bone. There's gas within the vertebral canal. Can't see any foreign body components within there, but clearly there is gas within here. So this needs an exploration. Clearly we don't know if there is clear cord injury here. There's clearly evidence of a PLC injury. So the patient had an MR before they went to exploration, and we can see that there's an expansion of the dorsal epidural space. There's gas locules as evidenced by these small foci of signal dropout. There's hematoma within that dorsal epidural canal. I think it's very hard to say whether there is injury here. I think there probably is. You can see a little bit of murky signal change at the level of the fracture, but what you can see is the tractive injury. So if you look here, you can see on the stir this tractive injury that traverses through that pars interarticularis, through that inferior aspect of the facet joint, and involves that posterior superior corner of the vertebral body. So there is likely to be a cord injury. The patient went for fixation, and what you can see now is the development of and progression and evolution of that cord laceration and edema that is extending through the cord at that level. And finally, to show you a last case, which is another translational injury, but it was one that came in on Friday, so I didn't want to not add this to the talk. So this is a translational injury of T9 over T10. So we have fracture of the inferior articular processes of T9. We've also got an anterior superior corner fracture of T10, and what's happened is we have translation of the T9 over T10 because there's been a fracture through the pars and the inferior articular processes here. There's associated bilateral T9 laminar fractures, and it looks like the superior aspect of that spinous process has been fractured, as well as the laminae either side of that. And as you can see, there's obviously severe canal narrowing at this level. So the patient went on to have an MRI, and again, this is another good one for looking at ligamentous injury. What you can see here, if we start to look at the ligaments in turn on the T2, the T1, the STIR and the T1, firstly looking at the T2. So what you can see here is that the ALL, I mean, it looks pretty much intact. It looks a little bit thinned, so it might just be stretched by this injury, by the burst-like fracture of that T10. Actually, it was an anterior superior corner fracture, not a burst fracture, sorry, apologies. And we've got a discal disruption here. You can see that there's herniation of disc material into that fracture. But we can see that there's clearly disruption of PLL. You can no longer see that PLL present. We can clearly see the focal defect in the flavum here. So let's have a look at that more clearly. So here's that focal defect in the flavum. Here you can clearly see that there's edema within the interspinous ligaments at that level as well. So the interspinous ligaments are gone. And here is this supraspinous ligament, and it's flapping about in the breeze here. So here is disruption, focal disruption of that supraspinous ligament. Okay, and what many of you will be noticing also is that clearly there is severe cord injury at this level. In fact, when we look more closely, we can see that the cord has in fact been transected at this level. So there is an injury through the cord is discontinuous. So this is a complete cord injury, and the patient was the worst Asia classification, which is the clinical classification of cord injuries, as one might expect. And the cord, distal to this also appears edematous with signal change. So that concludes the cases that I am showing as part of this. Some of these cases will be available as part of the hyperlinks, as part of the curriculum support tool. If you want to download that, you will be able to scroll through these cases in your own time. So to take away the key learning points from this, remember that thoracolumbar fractures often result from high energy injury, and neurologic and other injuries are common. Think about fracture pattern, not mechanism, when you're writing your reports. And remember that disruption of the PLC can actually be inferred from CT, but MRI is often required for full assessment. And remember to be wary of the ankylosed spine, have a low threshold for MRI. Thank you for listening, and thank you to my colleagues, especially Elizabeth Dick, who contributed cases.